Hi, this is Dr. Aditi Goimawala, and in this video we'll be dealing with the higher mental function examination of a child. This is part 2 of the CNS examination. The examination of the higher mental functions in children include cognitive functions, appearance and behavior, mood, content of thought, that is abnormal experiences, beliefs and perceptions. In the cognitive functions or the sensorium, we check for the level of consciousness, orientation, attention and concentration, memory that is recent and remote, and intelligence and judgment. I remember it as the child came and I went into coma. CAME in came stands for cognitive functions, appearance and behavior, mood and abnormal experiences, that is the content of thought. And I stands for intelligence, and coma stands for consciousness, orientation, memory and attention. We'll be dealing with language as a separate section. Although not localizing as specifically as sensory motor functions, certain parts of the sensorium appear to localize to particular brain areas. Consciousness and attention span to some degree is co-localized through the ascending reticular activating system. But there are so many other parts involved in consciousness we will deal with in some other video. Recent memory and orientation to person, time and place are impaired after lesions of the medial temporal lobes and the closely related hippocampal fornix mammillary body circuit and basal forebrain. But diffuse cortical and white matter lesions also impair these functions. Calculation has a nodal point in the left angular gyrus. Insight, judgment, planning are in large measure executive functions of the frontal lobes. Sensorial testing uses questions that require more or less objective answers for passing or failing. Example, either you know what day it is or you don't know what day it is. Sensorial deficits are sensitive to organic impairments of the brain. Sensory inputs from exteroreceptors, proprioceptors and interoceptors are processed in the sensorium through registration, recall, prioritization and integration. These leads to forecasting options and producing adaptive behaviors that support survival and satisfaction. First, we'll examine the consciousness and the mental state. Because you obviously cannot respond consciously when asleep, the sensorium is a property of the waking state. There are 3 methods to assess. The working category for practical purposes, Glasgow Coma scale and the 4 score. When we look at the working category, there are different terms used to describe the level of consciousness, but the degree of alertness varies and there is no fixed demarcation. Consciousness is a state of awareness of the self and surroundings and being responsive to various visual, auditory, tactile and thermal stimuli. Lethargic patient appears drowsy and may fall asleep even if not stimulated. Patient has difficulty in focusing or maintaining attention. Obtundation is difficult to arouse from a somnolent state and is frequently confused when awake. Repeated stimulation is required to maintain consciousness. Stupor. Patient responds only to strong, generally noxious stimuli and returns to the unconscious state when stimulation is stopped. When aroused, patient cannot interact with the examiner. Coma is a total state of unresponsiveness to even deep stimuli. Reflex motor responses may or may not be seen. A method commonly used to produce arousal in stuporous or comatose patients is to apply sharp pressure over the bony prominence like the supraorbital notch, fingertip pressure or a trapezius squeeze or a cutaneous nerve, and patient response is noted. Now we look at the Glasgow Coma scale and the Adelaide Coma scale, that is the modified Glasgow Coma scale, GCS. They are used for progressive assessment of an unconscious or comatose patient. It takes into consideration 3 things: eye opening, best verbal response and best motor response. This neurological tool is used to record the conscious state of the person for initial as well as the subsequent assessments. Its advantage is that it is a reliable and the values of the eye, motor and verbal responses are added to get the final score. The lowest possible Glasgow Coma scale score is 3, that is deep coma or death, while the highest is 15. Like the Apgar score, the total score for the 3 categories provide a prognosis. A GCS score from 3 to 8 implies a poor prognosis. The GCS should report the total score as well as the individual scores for each of these 3 items of the scale. Valuable as these scales are, some inter-examiner variability occurs. Then there is the modified Glasgow Coma scale. Rapid neurological assessment in children is done by using the modified Glasgow Coma scale. The Glasgow Coma scale was modified in relation to age, as adults and children respond differently to various stimuli. Then we have the 4 score, full outline of unresponsiveness score. Although the 4 score is based on the bare minimum of tests necessary for assessing a patient with altered consciousness, it includes much important information that is not assessed by the GCS, including measurement of the brainstem reflexes, determination of eye opening, blinking and tracking, a broad spectrum of motor responses and the presence of abnormal breath rhythms and a respiratory drive. Because the 4 score, unlike the GCS, does not include an assessment of the verbal response, it is more useful for assessing critically ill patients who have undergone intubation. Then we check for the orientation. If conscious and attentive, does the patient comprehend who and where he or she is and when it is? The orientation as to person, place and time requires ongoing sensory impressions. Have you ever wakened from a deep sleep momentarily disoriented as to the day, the hour or even where you were? If so, you had to process different afferent stimuli until all of the pieces of the puzzle suddenly fell into place. Self-orientation is the ability of the person to estimate one's own position with regard to time, place and person. The child may be disoriented in CNS infections and organic psychosis. To check for orientation in time, we ask the child, tell the day, month or year without looking at the calendar. Tell me the approximate time without looking at the watch. How long have you been in the hospital? To check for orientation in place, we ask, where are we right now? Which city or state is this? Which place do you live in? What is your home address? To check for orientation in person, we ask, what is your name? What is your middle name or surname? How old are you? And who is your mother or your doctor? सयूरी, आपका फुल नेम क्या है? आप कितने इयर्स के हो?
3 years.
आप गर्ल हो कि बॉय हो?
Girl.
वेरी गुड. यस. वो कौन है?
दादा दादी.
अच्छा. Attention and concentration. Attention is a cognitive process of selectively concentrating on one aspect of the environment while ignoring the others. To test for attention, the child could be given a number and asked to do sequential subtraction up to 0. Ask the patient to recite the months backward. Another way of testing attention is to say a 5-letter word, for example, water or world, and ask the child to spell it in a reverse manner. Then we check for the memory. Memory is a mental faculty that enables one to register, retain and recall previously experienced sensations, impressions, information and ideas. The brain retains and uses the knowledge gained in the past. Different types of memory are as follows. Immediate memory, that is the working memory. This consists of memory lasting for a minute or so. This can be tested by asking the child to reproduce a series of randomly selected numbers. Example numbers 1, 9, 5, 7, 2, 3 and 10, or names of 3 objects. Starting with series of 3 non-consecutive numbers, one number is increased each time until the child makes consistent errors in repeating. Most children are able to correctly repeat 7 to 8 numbers forwards and 4 to 5 numbers backwards. In organic dementia, Immediate working memory is impaired due to poor concentration and loss of ability and recall. However, distant memory is preserved. Then we look at the recent memory or short-term memory. The child is asked to reproduce an event that happened a few minutes back. For instance, the child can be asked to repeat a sentence told to him 5 minutes back. Or he can be told names of 3 objects of different categories after ensuring that the child has registered them. Other tests should be performed. After approximately 5 minutes, the child should be asked to recall the names of those items. Normal child can do this correctly in 3 attempts or less based on the ability to retain and retrieve. A child with normal retention but impaired retrieval is able to pick the answers from a list but is not able to recall well. There is something called as Korsakoff psychosis, wherein the recent memory and orientation to time are disturbed. Confabulation is common, wherein the patient tries to fill up the memory deficiency with other words. It is seen in children under 2 years of age, alcoholism and anterior hypothalamic lesions. Long-term or remote memory. This can be tested by asking the child to recall some events that happened long time back, that is many years ago. For instance, the child can be asked to name the place of residence 3 years back, or a college goer can be asked to name his first school, or a preschool if a child is in primary school. Then we come to the intelligence and judgment. Intelligence is the capacity to understand and the ability to reason, plan and solve problems, think abstractly, comprehend complex idea and learn from the experience. It is measured in terms of motor, adaptive, language and social behavior. It reflects the maturity and integrity of the CNS. The test for intelligence varies with age and educational status of the child. The intelligence quotient is measured as follows. Intelligence quotient is mental age upon chronological age into 100. Mental age can be assessed based on the child's performance in the tests. The IQ is less in children with cerebral cortical damage. Judgment is the ability of the person to estimate a situation to arrive at some conclusion and accordingly decide the further course of action. This can be tested by asking the child how he would react in a given hypothetical situation. To check for calculations, we can ask the child to count forward or backward, coin counting and making change, simple arithmetic, mental or return, serial subtraction, that is subtract 7 from 100 repeatedly, sequential doubling like 2 plus 2 4, 4 plus 4 8, 8 plus 8 16 and so on, column addition subtraction. तो आप अच्छा मुझे बताओ 5 plus 7 कितना होता है 7 वेरी गुड 20 minus 6 पहली बार आया था कितनी बार आया था और विटामिन में कंटीन्यूअस आया था क्या एक दिन में एक बार आया था ऐसे एक ही दिन में 3 बार आया था
20 minus
6 ये वाला दिखा दो ये हमारे से सारी खोलो और कोई दिक्कत नहीं है हमने हाँ कंटिन्यू करना ही पड़ेगा बस नहीं करना वो दवा चालू हाँ वो कट कर एमआरआई करना पड़ेगा. You can give them simple word problems according to their standards they are in. Like if I have 5 apples and I give you 2, how many apples I will have left? Or if the child is in higher standards, you can make it more difficult. So, what are the clinical insights? So, dyscalculia is a property of the dominant parietal lobe lesion, especially angular gyrus. And arithmetria is seen in Judgement syndrome. Posterior dominant hemisphere lesions may impair calculation and visospatial alignment. Aphasia is seen in paraphasic errors with numbers. Early Alzheimer's preserved basic calculation declines with disease progression. Educational levels affect performance rote facts. Example 2 plus 2 test. Remote memory more than calculation skill. Then how do we check for abstract thinking? So then we ask similarities or differences between apple versus banana, car versus airplane, lie versus mistake. Or then we can ask them analogies, like table is to leg as car is to, see what they answer, wheels, or what they say. Then we ask them to interpret the proverbs, like don't cry over spilt milk, a stitch in time saves 9. What does this mean to them? Sometimes you can ask them mixed or confusing proverbs, like the hand that rocks the cradle shouldn't throw stones. Tests abstraction and humor. So what does abstract thinking or deficit of abstract thinking tell us? So it suggests impaired abstraction, that frontal lobe disorders, common cause of abstraction deficits. Psychiatric illness may produce bizarre or literal interpretations. Cultural educational background affects familiarity with idioms and proverbs. Examiner clarity matters. Some proverbs are obscure even to clinicians. And then we check for the insight. Lack of insight is associated with lack of contact with reality. It is seen in psychotic illnesses, hysterical disorders, and anxiety states. So how do we check for insight and judgment? Traditionally, we ask questions like, what would you do if you found a stamped addressed letter on a sidewalk? What would you do if you smelled smoke in a crowded theater? This is more useful to assess insight into illness and its functional impact. Family history of real-life judgment often more reliable than hypothetical questions. So impaired judgment is seen in patients with impulsive or inappropriate behavior during exam. Common in neurological conditions affecting orbitofrontal regions. Lack of insight is seen in patients who deny illness or disability, often associated with non-dominant parietal lesions. Then we check for visual and body perception. Tests for parietal and occipital regions. Abnormality of perception of sensation despite normal sensory pathways are called agnosias. Agnosias can occur in all modalities of sensation, but in clinical practice, they usually affect vision, touch, and body perception. The sensory pathway needs to have been examined and found to be intact before a patient is considered to have agnosia. However, agnosia is usually regarded as part of higher function and therefore considered here. Facial recognition. Famous faces. Take a bedside newspaper or magazine and ask the patient to identify the faces of famous people. Choose people the patient will be expected to know. That is the Prime Minister of India, the famous Bollywood stars, or Miss Rachel in case of our children. Note the mistakes made. So if the child recognizes the faces, it is normal. If the child does not recognize the faces, then it is prosopagnosia. Body perception. The child ignores one side, usually the left, and is unable to find his hand if asked. That is hemi-neglect. Patient does not recognize his left hand if shown it. That is asomatognosia. Patient is unaware of weakness of the affected, usually left side, asognosia, and will move to the right side when asked to move to the left. Ask the patient to show you his index finger, ring finger, and so on. If the child is unable to do that, then the child has phygnoragnosia. Ask the patient to touch his right ear with his left index finger. Cross your hands and ask which is your right hand. Failure to do so suggests left or right agnosia. Sensory agnosia. Ask the patient to close his eyes. Place an object, that is a coin, key, paper clip, in his hand and ask him what it is. Failure to do so suggests astereognosis. Ask the patient to close his eyes, write a number or letter on his hand and ask him what it is. Failure to do so suggests agraphysthenia. Apraxia is a term used to describe an inability to perform a task when there is no weakness. incoordination or movement disorder to prevent it. It will be described here, though clearly examination of the motor system is required before it can be assessed. Tests for parietal lobe and premotor cortex of the frontal lobe function. Ask the patient to perform an imaginary task. Show me how you would comb your hair. Drink a cup of tea. Strike a match and blow it out. Observe the patient. If there is difficulty, give the patient an appropriate object and see if he is able to perform the task with an appropriate prompt. If there is further difficulty, demonstrate and ask him to copy what you are doing. If the patient is able to perform the act appropriately, it is normal. If the patient is unable to initiate the action through understanding the command, that is ideational apraxia. The patient performs the task but makes errors. For example, uses his hand as a cup rather than holding an imaginary cup, that is ideomotor apraxia. If inability is related to a specific task, like for example, dressing, this should be referred to as a dressing apraxia. This is often tested in hospital by asking the patient to put on a dressing gown with one sleeve pulled inside out. The patient should normally be able to overcome this easily. Something called as the 3-hand test. Ask the patient to copy your hand movements and demonstrate. Make a fist and tap it on the table with your thumb upwards. Then straighten out your fingers and tap on the table with your thumb upwards. Then place your palm flat on the table. If the patient is unable to perform this after one demonstration, repeat the demonstration. If the patient is unable to perform this in the presence of normal motor function, limb apraxia. 3 patterns can be recognized. Patient with poor attention. Tests are useful to document the level of function, but are of limited use in distinguishing focal from diffuse disease. Patient with deficits in many or all major areas of testing indicates a diffuse or multifocal processes. If of slow onset, dementia or chronic brain syndrome. If of more rapid onset, confusional state or acute brain syndrome. So how do we localize this? Impaired attention and orientation occurs with diffuse disturbance of cerebral function, if acute, often associated with disturbance of consciousness. If chronic, limits ability for further testing. This is suggestive of dementia. It also occurs with anxiety and depression. Memory. Loss of short-term memory in alert patient, usually bilateral limbic system, that is hippocampus memory body disturbances, seen in diffuse encephalopathies, bilateral temporal lesions, prominent in Korsakoff psychosis, that is thiamine deficiency. Loss of long-term memory with preserved short-term memory occurs in functional memory loss. Calculation. Impaired calculation usually indicates diffuse encephalopathy. If associated with finger agnosia, inability to name fingers, left-right agnosia, inability to distinguish from left to right, and dysgraphia, that is Judgement syndrome, indicates a dominant parietal lobe syndrome. Perverse but consistent calculation errors may suggest psychiatric disease. Abstract thought. If interpretations of proverbs are concrete, suggest diffuse encephalopathy. If interpretation includes delusional ideas, suggests psychiatric illness with particular frontal lobe involvement. Poor estimate suggests frontal or diffused encephalopathy or psychiatric illness. Loss of spatial appreciation, that is copying drawings, stereognosis, that is parietal lobe lesions, visual and body perceptions. Neglect include parietal lobe lesions. Sensory agnosia, that is astereognosis, agraphesthenia, apraxia. Ideomotor apraxia, lesion of either the dominant parietal lobe or premotor cortex or a diffuse brain lesion. Ideational apraxia suggests bilateral parietal disease. Then we check for rapport. If the child is maintaining a normal relationship with others, this depends on the personality and mental attitude of the child. Then we look at the appearance and behavior. Appearance of the child gives clue about his neurological status. Note his dressing sense and personal hygiene. Self-neglect is seen in depression, dementia, and other psychotic illnesses. Behavior is the way in which the person reacts to the internal and external stimulus. Note if it is normal or abnormal. This should be assessed in terms of attitude to self, relationship to others, level of independence, mood, fantasy life, religious beliefs, interests, and hobbies. For example, certain types of behavior give a clue to the underlying disease. So, example, avoidance of eye contact and self-engrossed in autism, irritable and excessive crying in cerebral irritation due to various causes, self-mutilating behavior in Lesch-Nyhan syndrome. Then we check for the mood, that is the mental and the emotional state. The child may be apathetic, irritable, anxious, excited, depressed, frightened, euphoric, alert, dull, not interested in surroundings, etc. The clinician should note if the emotions of the child are appropriate as per the circumstances or not. Some of the abnormalities of emotion are as follows: anger, a strong feeling of displeasure or hostility. If there is inappropriate crying or laughing, the child may cry after hearing a joke or may laugh after being punished. It may smile in severe depression. Look if the child is irritable. Elation, the child may be happier than the circumstances would warrant. If you have cause to cry or laugh, how much provocation does it take to make you start, and how much time does it take you to get over it? If the patient cries for 15 seconds and then starts to laugh when you ask him to tell you a funny story, the patient has affective lability. The opposite of affective blunting. Affective lability, on and off laughing and crying, commonly accompanies bilateral upper motor neuron disease, as we have seen in pseudobulbar palsy and diffuse brain lesions. First, we look at illusion. Everyone has experienced the illusion of water shimmering on a hot highway on a summer's day. The water is an illusion. Illusion is a false sensory perception based on the natural stimulation of the sensory receptor. The healthy person recognizes the illusory nature of such an experience, but the sick person may not be able to do so. Then we look at hallucination. Hallucination is a false sensory perception not based on natural stimulation of a sensory receptor. The mentally ill patient usually does not recognize the hallucination as a false representation of reality, whereas the patient with epilepsy does. Hypnagogic or hypnopompic hallucinations are not true hallucination. A hypnagogic hallucination represents wakeful dreaming while falling asleep, while a hypnopompic hallucination represents wakeful dreaming immediately after waking up. Then there are delusions. Delusion is a false belief that reason cannot dispel. Then we look at the mental and emotional state. The mental and emotional state of a child depends on various factors, including the health status. For instance, a child who is sick will not be interested in the surroundings. By observing a child, the health status may be assessed by some extent. Types of mental and emotional states are happy, playful, alert, and interested in the surrounding. That is a normal healthy child. Anxious, anxiety neurosis. Elation, a feeling of well-being or excitement in bipolar mania. Euphoria, an exaggerated feeling of well-being often not justified by circumstances. Depression, depressive psychiatric disorders. Restless, hyperactive child and child with pain. Dull, not interested in surroundings, apathetic or irritable in protein energy malnutrition. Shy and timid or obstinate, seen in overprotected children.